Today we will discuss ultra-minimally invasive colorectal surgery. Utilizing these ports, you can perform all sigmoid resections and low anterior resections. Left-sided intracorporeal anastomotic techniques will be discussed. Case 1 involves a 72-year-old female with a colovaginal fistula caused by chronic diverticulitis. A robotic LAR was performed. The colovaginal fistula had been taken down. The tissue to be used for the anastomosis was examined with fluorescence angiography. The anvil was placed into the abdomen through the right lower quadrant port site. The anvil was placed into the left paracolic gutter. A colotomy was made distal to the proximal transection site using the vessel sealer. The grasper is used in the right hand to maneuver the anvil into the colon. The anvil is brought out through the antimesenteric border of the conduit. The device is then turned to face toward the pelvis. Sutures are brought into the abdomen by the assistant. The spike is removed from the anvil. Utilizing a barbed suture, the colotomy is closed in a running full-thickness fashion using the vessel sealer as a needle driver. An absorbable suture is then utilized to make a purse string around the anvil. The purse string is completed and the sutures are removed from the patient's abdomen. The stapler is then introduced through the right lower quadrant port site. A green cartridge is used to transect the colon just distal to the anvil. The colon is then pulled out of the pelvis to bring the distal transection site into view. The green cartridge is again used to transect the rectum. Because of the angle while working in the pelvis, a second firing using the same stapler is placed across the remaining portion of rectum. The rectal stump is seen to be well vascularized. The circular stapler is brought to the end of the rectal stump and opened. The anvil is connected to the stapler. The colonic conduit is examined and is not twisted, and the stapler is fired, opened, and removed. The anastomosis is placed under saline and the proximal bowel is gently occluded. A flexible sigmoidoscopy is performed and there is no evidence of a leak. Fluorescence angiography reveals a well-perfused anastomosis. Sutures are used to imbricate the anastomotic staple line. Once completed, the pelvis is irrigated. A porcine bladder xenograft is then placed into the pelvis and situated above the anastomosis to block this area from the colovaginal fistula. Fibrin glue is placed above and below the xenograft to secure the device in place. She was discharged on postoperative day 1. Case number 2 involves a 42-year-old female with a colonic obstruction. A loop colostomy was performed. A robotic left colectomy was then completed. The left-sided mobilization was completed, including the entirety of the splenic flexure. The distal transverse colon was transected with a green robotic cartridge. The specimen included the previously placed loop colostomy. Fluorescence angiography was utilized prior to firing the staples. The distal staple line was cauterized. The entirety of the sigmoid colon was mobilized. The sigmoid colon was then brought up toward the mid-abdomen. The redundant transverse colon was brought alongside the sigmoid colon in an anti-peristaltic fashion. A colotomy was made approximately 10 centimeters proximal to the transverse colon staple line. This same maneuver was then done to the sigmoid colon. A green robotic cartridge was then introduced into both limbs of the colon and the common channel was formed. A suture was placed at the medial portion of the remaining colotomy. The importance of this suture will be seen while the colotomy is closed. A barbed suture is then used to perform a full-thickness closure in a running fashion of the remaining colotomy. Each suture is placed carefully to ensure that no gaps are left in place. As the sutures are brought through the colon, the loops are then controlled to ensure proper placement of the stitch. The vicral suture is held on tension to bring this area in better view. The running suture is continued beyond the level of the vicral to ensure that the colotomy has been completely closed. The suture is brought back in the opposite direction to lock it in place. The laxity of the tissue allowed this second layer to be formed in a running Lambert fashion. This second layer completely imbricates the primary closure. As can be seen, the loops are controlled so that all of the sutures are placed down flat. The suture is again run back towards itself to lock it in place and then cut. The anastomosis is seen to be intact during sigmoidoscopy. Fluorescence angiography reveals a well-perfused anastomosis. Fibrin glue is placed. She was discharged on postoperative day 1. Case number 3 involves a 62-year-old male with colon cancer. There was no evidence of metastatic disease. A robotic left colectomy was performed. The tumor is located at the mid-descending colon. The entire left colon was mobilized. Fluorescence angiography revealed well-perfused bowel. The proximal colon was transected with a green cartridge. Remaining soft tissue attachments were taken down using the vessel sealer. The distal well-perfused bowel was then transected with another green cartridge. An additional firing was used to complete the transection. The specimen was grasped and was brought away from the conduit. The well-mobilized proximal colon was brought down to the pelvis. The sigmoid colon was then aligned with the descending colon in an isoperistaltic fashion. The sigmoid colon is placed medial to the descending colon. The sutures are placed into the abdomen. A vicral suture is placed to keep the bowel aligned. A colotomy is then made near the staple line of the descending colonic conduit. The same maneuver is then performed approximately 10 centimeters distal to the staple line on the sigmoid colon. The stapler with a green cartridge is then introduced into the colon. Once the bowel is aligned correctly, the stapler is fired and removed. A second green robotic cartridge is advanced into the colon, and the common channel is lengthened. As is standard in our practice, a vicral suture is placed at the medial portion of the remaining colotomy. The importance of this suture will again be seen during the closure of the colotomy. A barbed suture is utilized to perform a full thickness closure of the colotomy. This is begun at the lateral portion of the open bowel. Each bite is placed carefully so as not to leave any gaps in the closure of this area of the intestine. This is brought beyond the previously placed vicral to ensure that the entirety of the colotomy has been closed. Another barbed suture is used to form a second layer. In this case, the second layer is done directly below the primary closure. Again, the suture is run directly toward and past the previously placed vicral. The sutures are gathered and removed from the patient's abdomen by the assistant. Fluorescence angiography is performed and reveals a well-vascularized anastomosis. A flexible sigmoidoscopy is then used to perform a leak test. The proximal bowel is occluded and saline is placed over the anastomosis. The remaining fluid is suctioned out of the abdomen and pelvis. Using a flexible catheter, fibrin glue is placed over the suture lines and staple lines. The anastomosis is seen to have no tension. He was discharged on postoperative day 1. Intracorporeal surgery provides useful techniques. This port placement will allow you to perform a right colectomy, a reversal of a loop ileostomy, and a right-sided small bowel resection. This video will display the surgical management of a 61-year-old female with metastatic colon cancer to the liver. The primary tumor was located in the transverse colon, and the liver metastases were located in segments 5 and 6. She received neoadjuvant chemotherapy and was then brought to the operating room. The robotic liver resections can be viewed on the full video. The omentum was placed into the upper abdomen to bring the transverse colon into view. The ileocolic axis is placed on stretch. The peritoneum at the base of the ileocolic vessels is opened and a medial to lateral dissection is performed. This dissection brings the duodenum into view. The duodenum is fully mobilized so that a high ligation can be performed. The ileocolic vessels are ligated at their origin using the vessel sealer. The remaining attachments around the duodenum and the right kidney are taken down. At this point, the medial to lateral dissection had been completed across the hepatic flexure. The omentum is brought down, exposing the gastrocolic ligament. The lesser sac is opened using the vessel sealer, and the previous dissection is encountered immediately. With the duodenum being completely mobilized, the hepatic flexure can be taken down quite quickly. The remaining lateral attachments are then taken down using the vessel sealer. Starting at the previously transected ileocolic vessels, the mesentery of the terminal ileum is taken down using the vessel sealer. The mesentery is ligated all the way to the bowel wall. The ileum is grasped and easily reaches up toward the transverse colon. The omentum is mobilized away from the transverse colon, distal to the tumor. This allows the involved omentum to be included with the specimen. The remaining transverse colon mesentery is then transected using the vessel sealer. This is done until the bowel wall is reached. An instrument is placed under the colon, ensuring that all attachments have been taken down. A small omental band is taken down to complete the dissection. The patient is injected with 4 milliliters of indocyanine green. Well vascularized transverse colon is then transected using the robotic stapler with a green cartridge. Once the transverse colon has been transected, a blue robotic cartridge is placed across the terminal ileum. The well vascularized small bowel is transected using the stapler. The specimen is placed above the liver on the right side. This maneuver clears the area in preparation for formation of the anastomosis. It also proves that the specimen is completely free of all of its attachments. The area is irrigated and no bleeding is seen. Some of the omental attachments are taken down so that the transverse colon easily reaches the right side. The terminal ileum is aligned with the transverse colon in an isoperistaltic fashion. The antimesenteric border of the small bowel is removed. A colotomy is then made in the transverse colon, approximately 10 centimeters away from the staple line. A green robotic cartridge is placed into the terminal ileum and the transverse colon. This firing of the stapler creates the ileocolic channel. The stapler is then reintroduced to lengthen the anastomosis. At this point, the anastomosis is approximately 11 centimeters in length. With the help of an assistant, the remaining enterotomy is grasped. Once aligned, a green robotic cartridge is used to close the remaining enterotomy. The small anastomotic edge is removed from the abdomen. Fluorescence angiography is again utilized, and the anastomosis is seen to be well vascularized without any defects. There was a small amount of bleeding from the final staple line that was fired. Figure of 8s are placed using absorbable suture. Placing these sutures to obtain hemostasis can be done quite easily using the robotic platform. Fibrin glue is then placed over the staple lines. The omentum is brought down to cover the anastomosis. The specimen is then brought down to the lower abdomen in preparation for extraction through the phalansteal incision. The liver specimens are also brought down to the lower abdomen. She was discharged home on postoperative day 3. All of the margins were negative. The suprapubic extraction site was well healed at her 1-month postoperative visit. Patients who have undergone prior surgery receive some of the greatest benefit from the robotic platform. This operation could not have been performed laparoscopically. A 70-year-old male with a history of Crohn's disease was diagnosed with a low rectal cancer involving the sphincter complex. An enlarged inguinal lymph node was biopsied and revealed metastatic disease. Flexible sigmoidoscopy revealed a tumor extending to the anal verge. MRI revealed a T2N1 tumor. He was treated with total neoadjuvant therapy. The right groin was included in the radiation field. The inguinal lymph node resolved and will be observed. The tumor appeared much smaller after total neoadjuvant therapy. He received preoperative stoma marking in preparation for an APR. The abdomen was entered in the left upper quadrant and severe adhesions were visualized. Additional robotic ports were placed on the left side after flimsy adhesions were mobilized. As seen here, the abdomen was essentially frozen from the prior ileocolic resection, which had been performed over 30 years ago. The normal anatomy could not be visualized and the pelvis could not be seen. Over the next 3.5 hours, a lysis of adhesions was performed. Following the prior operation, the abdomen had reperitonealized in an unusual fashion. It appeared that numerous loops of bowel were adherent to the preperitoneal space on the right side. These adhesions were taken down sharply in an attempt to restore normal anatomy. An area of small bowel was extremely fixed to the abdominal wall, which appeared to represent an enterocutaneous fistula, and this was taken down using the robotic stapler. At this point, it became more clear that the abdomen had been separated into numerous compartments. The peritoneum on the right side was held up so that the small bowel could be brought away from this tissue. In doing so, the pelvis eventually revealed itself. The rectal dissection was begun by incising the peritoneum at the base of the sigmoid colon. The presacral space was entered and the posterior dissection was performed, and this was then taken along the left and right sides. The dissection was continued circumferentially until the deep pelvis was entered. This was done with the aid of the robotic suction. An abscess cavity was encountered posteriorly. This appeared to represent a perforation of the tumor. Rectal exam was performed and the rectum had not been entered during the dissection. The patient was injected with indocyanine green. The portion of the colon that would eventually become the colostomy had an excellent blood supply when viewed with fluorescence angiography. The colon was transected using the robotic stapling device. An additional firing with the stapler was utilized to complete the transection of the colon. Once the transection had been completed, the deep pelvis was evaluated. After irrigating the pelvis, the colostomy was matured and the patient was then turned to the prone position. An incision was then made around the anus, including a portion of the sphincter complex. The dissection was then continued until the abdomen was entered. The final anterior attachments were taken using the vessel sealer and the specimen was removed. The specimen did not reveal a large perforation. The pelvic drain was brought out through one of the left-sided port sites. A silver impregnated dressing was placed over the perineal wound. He was seen in the office 1 week after surgery for additional colostomy teaching. Pathology revealed negative margins. Robotic oncologic surgery can be performed even in the case of widespread adhesive disease. The robotic platform can also be used to perform transanal surgery. A single access port designed for use within the rectum is placed and the robotic platform is docked. Marks are then made around this early stage rectal cancer and a full thickness dissection is performed. In this case, the majority of the dissection is performed with the spatula, but more commonly I use the scissor. Although this operation can be performed using laparoscopic equipment, the wristed instruments allow for a much better dissection and allow for extremely complex maneuvers to be performed. This is a straightforward example of this type of surgery. Once the specimen is completely removed, the area is irrigated and the suture is placed into the rectum. This is a barbed suture which does not require the placement of any knots. Using the robotic needle driver, the defect is closed in a running fashion from distal to proximal. Performing the closure in this manner ensures that the lumen is not strictured. Much more complex transanal surgery can be performed and can be viewed on the YouTube channel. Practice is completely robotic and completely intracorporeal. Intracorporeal surgery means that the entire operation is performed within the patient's body and only at the end of the operation is an incision enlarged so that the specimen can be removed. In cases where an ostomy is being formed, the ostomy site is always used for extraction, which negates the need for another incision. In certain circumstances in women, the specimen can also be brought out through the vagina, which also negates the need for another incision. A series of emergent and elective procedures will now be shown to demonstrate the full breadth of what can be accomplished robotically. This patient had a sigmoid cancer and noticed the very small extraction site in the right lower quadrant. This patient presented with a giant lipoma emanating from the colon, which caused a prolapse through the anus. He was originally taken to the operating room and a laparotomy was performed by another team. They were unable to identify the lesion, and eventually I brought him to the operating room for a robotic resection of the giant lipoma performed through a colotomy made in the left colon. The full video was presented by one of your co-residents and can be viewed on the YouTube channel. This patient sustained a colonic perforation during a colonoscopy caused by a single adhesion to the vaginal cuff. This was an emergent case performed at night, and she underwent a robotic repair of the colon. She did not require an ostomy, and only 8mm ports were utilized. The full video was presented by one of your co-residents at a major conference. This patient underwent a sigmoid resection for diverticulitis and once again noticed the very small extraction site in the right lower quadrant where the 12mm port had been located. This patient underwent a robotic intracorporeal resection of the splenic flexure for treatment of a cancer. Intracorporeal surgery was again utilized, and the extraction site was the 12mm port. This operation was performed on December 10th, 2021. Please keep this date in mind as it will become important. The second operation performed on December 10th, 2021 was a robotic right colectomy with an intracorporeal anastomosis for treatment of an ascending colon polyp. In the right colectomy, the extraction site is a suprapubic incision where the lower port site is enlarged. This is another patient treated for diverticulitis with a sigmoid resection and the same incisions that you have seen. This patient was treated for Crohn's disease with high-grade dysplasia of the colon. A robotic total colectomy with an iliorectal anastomosis was performed. Once again, the extraction site is in the right lower quadrant where the staple port had been removed and enlarged. This patient underwent a robotic abdominoperineal resection for treatment of rectal cancer. These patients do not require enlargement of any of their incisions. The specimen is removed during the prone portion of the case when the anus is removed. This patient sustained a stercal perforation of the rectosigmoid junction and was taken to the operating room emergently in the evening. She underwent a robotic resection with end colostomy. The same methods can be used in the emergent setting as in the elective setting if the proper experience and skill is performed in conjunction with the proper equipment. This case has also been presented by your co-residents and can be reviewed. This patient underwent a robotic low anterior resection for treatment of rectal cancer. Again, note the very small extraction site in the right lower quadrant. This slide presents an important point. The cases that you have just been shown are not cherry-picked from a larger number of operations. They are a direct reflection of the way my practice works. In May of 2024, I performed 17 colon and rectal resections. They were all performed robotically, and they were all performed with an intracorporeal anastomosis. This patient presented this past week. She is a 56-year-old female who was found to have diverticulitis with a perforation and abscess, and she presented with peritonitis on physical examination. Because of her diffuse abdominal pain and tachycardia, she was brought to the operating room emergently. The perforation was visible in the sigmoid colon. Small bowel had walled off the area and was moved away. The perforation is seen in the image in the upper right corner. With the assistance of one of your third-year co-residents, I performed a robotic sigmoid resection with intracorporeal anastomosis and loop ileostomy. The lower right picture reveals the anvil being placed as seen previously in this video, and the lower left reveals the anastomosis. She did quite well and was ready for discharge on postoperative day 3. As discussed in the previous cases, the right lower quadrant port was used for anvil placement into the abdomen, specimen extraction, and ultimately for formation of the loop ileostomy. Because of the minimally invasive technique utilized in this operation, she will be able to undergo loop ileostomy reversal very soon in approximately 6 weeks. As I have stated, the methods that are used electively can easily be translated into the emergent situation. This video can be edited and presented by any of our residents, including, of course, the resident that was involved in the case, and presented at an upcoming conference. Our intuitive colleagues have provided us with this information, which shows that robotic surgery does in fact save money and provides good outcomes and short hospitalizations. As a general statement, most of my patients who undergo an elective resection without an ostomy are discharged on postoperative day 1. I would like to leave you all with some final thoughts. I would like to stress again that the cases that we have just discussed are not cherry-picked and represent my practice performing ultra minimally invasive colorectal surgery with intracorporeal anastomoses. After many years of performing these operations utilizing these techniques, I can honestly tell you that nearly every single case that is presented to you can be performed in a minimally invasive fashion. This includes urgent cases, emergent cases, and of course the elective cases. It also includes all different types of pathology, including benign cases as well as malignancies. Obviously, there will always be a role for open surgery, and I myself recently performed a major open operation in a patient who had numerous complications from a prior operation performed by another surgeon. However, I do think that we have come to a point that, at least in the world of colorectal surgery, open operations probably only need to be utilized approximately 1% of the time. I invite you all to take this journey with me. I want you to take a good look at the diagram on this slide. We must be safe when operating, and we must perform an effective operation which is appropriate for the pathology and the patient's presentation. The surgeon must choose their operation based on their skill and their set of tools, and also based on the equipment that is available. When all of these things come together, you end up with that very small pentagon seen in the middle of the Venn diagram. This very small area is where I have chosen to spend my entire career. It can sometimes be a difficult place to exist, and the stress level can be high, but the rewards for your patients and yourself are even greater. I asked you to keep in mind the date of December 10th, 2021, where I performed a colectomy on the left side at the splenic flexure, as well as a right colectomy. Both of these patients were discharged on postoperative day 0. They did not spend any time in the hospital and were discharged from the recovery room. This has become a fairly common occurrence, and approximately 20 to 25% of my elective colon resections in patients who do not require ostomies are discharged on the same day that the surgery is performed. The robot is a tool, and this is extremely important to remember. It is not a replacement for surgical skill, and it will not make up for any deficiencies in your surgical training or knowledge. But it is a tool that has offered great benefit and significantly enhances the way that we can treat and manage our patients. Not all of the surgeons that you will work with will agree with everything that I have said during this conversation. There is nothing wrong with that, and we are all entitled to our opinions. But I invite you to work with me here at the tip of the spear. I promise you that if you spend the next years working hard, learning, reading, spending time in the operating room, and taking in as much as you can from the experiences that you will be provided, then all of what you have seen today will be possible. I was not born knowing how to do these things, and I certainly did not finish my residency knowing how to do these things, particularly because at that time, robotic surgery was not even being utilized at my general surgery residency. But my promise to you is that if you give everything that you can, you will all eventually be able to do what you have seen today.
Here's to the crazy ones, the misfits, the rebels, the troublemakers, the round pegs in the square holes, the ones who see things differently. They're not fond of rules, and they have no respect for the status quo. You can quote them, disagree with them, glorify or vilify them, but the only thing you can't do is ignore them, because they change things. They push the human race forward. And while some may see them as the crazy ones, we see genius. Because the people who are crazy enough to think they can change the world are the ones who do.